Welcome to Milestones, your daily snapshot of maternal nutrition breakthroughs. Today, Professor Andrew Prentice is joined by Dr. Nandita Perumal to discuss healthy weight management in pregnancy.
Welcome to another of our podcasts on Milestones in Maternal Nutrition, part of the wider series of NNI Bites Big Learnings. I'm your host, Andrew Prentice. Today we're talking about a really important topic, healthy weight management in pregnancy. And I'm very pleased to be able to welcome an expert in this field, Dr. Nandita Perumal from the University of South Carolina in the US. Welcome, Nandita.
Thank you for having me.
Huge pleasure. Dr. Perumal's research program aims to improve maternal and child health, nutrition, and neurodevelopmental outcomes in vulnerable populations by investigating the causes and consequences of adverse exposures during pregnancy. She did her initial training in Canada, gaining a BSc in Human Nutrition from McGill and an MPH and PhD in Epidemiology from the University of Toronto. She then completed her postdoctoral research in the Department of Global Health and Population at the Harvard T.H. Chan School of Public Health in Boston. She's now an assistant professor in the Department of Epidemiology and Biostatistics in the Arnold School of Public Health at the University of South Carolina. Now, this is a truly fascinating topic since a woman's body weight has profound effects on many aspects on reproduction, ranging from when she enters menarche, her ovulation patterns, and hence her likelihood of conceiving, and then some really significant effects on pregnancy outcomes and even on lactation. So we've got a lot to talk about. Nandita, let's start with fertility. Evolution has equipped us with some very clever tricks insofar as what we call the hypothalamic pituitary ovarian, or the HPO axis, is exquisitely sensitive to a woman's energy balance. And it suppresses ovulation when it judges that there's not enough energy to start a reproductive cycle. Underweight gymnasts, ballerinas, fashion models, and athletes are the best known examples of this. And here in the Gambia, we get far fewer conceptions in the hungry season than in the harvest season. But these are relatively extreme examples. Can you tell us, Nandita, about the less extreme effects of energy stores, in brackets, fatness, on fertility? Maybe citing the well-known research on infertility in the American Nurses' Health Study from your alma mater, Harvard.
Certainly. Thank you, Andrew. That's a perfect framing. The example that you listed for the Gambia is a really interesting and elegant example of a natural experiment for exactly the phenomena we're discussing. The Nurses' Health Study, or NHS, is a large prospective cohort of over 116,000 female registered nurses that began in 1989 that has given us the first rigorous population-level evidence for the less extreme end of this relationship in American women. In their landmark paper in 2002, the study authors really tracked the incident ovulatory infertility against body mass index, or BMI, and physical activity levels in over 26,000 pregnancies, among which there were 830 confirmed cases of ovulatory disorder infertility. So what the researchers found was incredibly interesting, and they showed that the data demonstrated a U-shaped relationship between BMI and ovulatory infertility risk, meaning that the risk was elevated both at the lower end, so among women with a BMI below 20, and at the higher end, so among women with a BMI above 24. And that this curve was actually not symmetric, which means that among women with BMI of greater than 35, the relative risk of ovulatory infertility was substantially higher, almost double that of women between the BMI range of 20 to 24. Crucially, when the authors applied those risk estimates to the actual BMI distribution of US women, they calculated that about 25% of ovulatory infertility in the US was attributable to women being overweight, having a BMI greater than 25, compared with only 12% of attributable risk among women who were underweight, so BMI of less than 20.
Thanks, Nandita. So that's really, really strong evidence, especially coming from such a large sample size. Now, an extreme manifestation of the link between being overweight and being subfertile comes in the form of polycystic ovarian syndrome, PCOS. Can you briefly summarize that relationship, the relationship between overweight and PCOS? If I'm not mistaken, there's strong evidence for a two-way relationship.
Before I answer the substantive question, I should flag something that the listeners will want to know, that this condition has recently officially been renamed. In May 2026, a landmark global consensus that was published in The Lancet by TB and colleagues noted that what we have been long calling polycystic ovarian syndrome, PCOS, will henceforth be known as polyendocrine metabolic ovarian syndrome, or PMOS. And this is because the old name was inaccurate on two counts. It noted polycystic, which implied that there was a presence of pathological ovarian cysts that are not actually a feature of the condition. And the narrow definition or ovarian framing around the definition obscured its true multisystem nature. Therefore, the new name reflects the condition's genuinely polyendocrine character, its central metabolic dysfunction, and its ovarian involvement while dropping the misleading cyst reference. Now, onto the substantive question of how does PCOS or PMOS affect obesity and vice versa. There is substantial evidence that shows that PMOS, which is commonly an endocrine disorder that affects around 1 in 8 women of reproductive age, is indeed bidirectionally associated with overweight. And though much of the evidence suggests that the primary direction of obesity driving PMOS rather than the reverse. And this pathophysiology is genuinely polyendocrine, involving 3 interactive systems: the central neuroendocrine dysregulation, insulin resistance, and the ovarian endocrine disruption. Clinically, this is important because even modest weight loss, around, say, 5% of body weight, has been shown to meaningfully improve insulin sensitivity, lower the androgen levels, and restore ovulatory cycles in many women. Weight management is therefore a cornerstone of PMOS treatment. And in the broader context of this podcast, the name change itself also matters here, because about 70% of affected individuals remain undiagnosed globally, partly because the old name fostered confusion both among patients and clinicians about the condition's true systemic nature. The new name, therefore, better reflects this polyendocrine and metabolic reality that should really help in the alignment of the diagnosis, the research funding, and the policy to really where the science actually is.
Thanks, Nandita, and thanks for updating me on that new terminology. Now, in the rest of the podcast, we're going to be describing the evidence that being overweight or obese carries many risks in pregnancy. But before we go there, I think it's quite important for me to point out that the vast majority of overweight mums do perfectly well in pregnancy and end up with a lovely, bouncing baby. The risk ratios we're going to be talking about are important, and they shouldn't be underestimated, but they are population-wide risks. I just wanted to remind listeners of that. Now, you've described how energy balance and either having too little or too much body fat can influence the likelihood of a woman ovulating and conceiving. Can you next walk us through the stages of pregnancy? And as just mentioned, in this next part, we'll be concentrating largely on the harmful effects of being overweight. Now, even if a woman ovulates successfully, several IVF studies have shown that they may have lower quality eggs and hence a lower success rate in assisted fertility. But let's assume that conception has occurred successfully. Can you briefly touch on how obesity can influence 2 very undesirable outcomes in the early stages of pregnancy? Risk of having a baby with a neural tube defect and the risk of early fetal loss.
You're right. Even before we get to the later stages of pregnancy, obesity has been associated with an increased risk of both of these 2 serious early complications. The first one being neural tube defects, or NTDs. A large meta-analysis of 12 studies has found that compared with normal weight women with obesity have about 1.7 times, and those with severe obesity had about 3 times higher odds of having a pregnancy that's affected by neural tube defects compared to normal weight women. Critically, this elevated risk was not simply explained by lower folate intake or non-use of supplements, which is one of the main causes of neural tube defects that we know. And the likely mechanisms include impaired folate metabolism. For instance, for obesity, there's an association between folate sequestration in adipose tissue and altered carbon metabolism, in addition to chronic hyperglycemia disrupting early neural development and oxidative stress. The other serious complication is early pregnancy loss. Obesity, for example, has been associated with an increased risk of miscarriage. In meta-analyses, researchers have found that women with obesity have approximately 30 to 70% higher risk of first trimester miscarriage compared with normal women, and the risk of recurrent pregnancy loss is also elevated.
Thanks, Nandita. And we're about to move on to those later stages and discover that there are further consequences, as you've just hinted. So before we turn to that evidence that obesity is associated with a range of poor outcomes at delivery for the baby, let's first run through the effects on the mum, and particularly her risk of gestational diabetes and hypertension.
Certainly, gestational diabetes mellitus, or GDM, and hypertensive disorders of pregnancy are two of the most clinically significant maternal risks during pregnancy. Pregnancy is inherently a state of progressive insulin resistance, which is really driven by placental hormones like human placental lactogen, progesterone, and cortisol as a mechanism to redirect glucose to the growing fetus. So these are really essential mechanisms that are at play. In women who are already insulin resistant before pregnancy because of excess adiposity, this additional physiological change pushes many women over the threshold into clinical GDM. Large systematic reviews consistently find that overweight women have approximately threefold higher risk of GDM compared to normal weight women, and this risk increases further with increases BMI. Gestational diabetes mellitus itself carries with it substantially elevated risk in the long term for type 2 diabetes for the mother, with approximately 50% of moms with GDM being estimated to go on to develop type 2 diabetes within 10 years after pregnancy that's affected by gestational diabetes mellitus, which is quite high. The other serious complication that can occur in pregnancies are hypertensive disorders of pregnancy, such as gestational hypertension, preeclampsia, and eclampsia. Obesity is one of the strongest modifiable risk factors for preeclampsia and gestational hypertension. And in a large cohort study, there's been shown that relative to normal weight women with obesity had almost a 5-fold higher risk of gestational hypertension and nearly a 9-fold higher risk of preeclampsia. So these are fairly serious complications to the mom associated with obesity in pregnancy.
They are indeed. And you've just educated me, because although I was aware that the risk of gestational hypertension was higher in overweight women, I was not aware of the association with preeclampsia. And you've just told us that the odds ratios for that at 9, I think you said, were even higher. So let's now talk about the risk of maternal obesity on the baby itself.
Yes, the risks to the baby span the full spectrum from structural anomalies through to fetal growth disorders to long-term developmental programming effects. Among the most consistently reported fetal consequences of maternal obesity are large size at birth. And this can be defined both by the birth weight alone. So having a birth weight greater than 4,000 grams, for example, is defined as being macrosomia. Or it can also be defined as being large for gestational age, which is being above the 90th percentile for birth weight for a given gestational age and sex based on the standard reference population. So this would be, for example, the intergrowth newborn size standards. In meta-analyses, maternal obesity has been consistently associated with more than double the odds of macrosomia and over 2 times the odds of having a newborn with large for gestational age. Macrosomic infants and those that are born large for gestational age then face elevated risk of shoulder dystocia during childbirth, birth trauma, neonatal hypoglycemia, and even NICU admission. Some of the other consequences for the fetus include higher risk of stillbirth, congenital anomalies, and preterm birth. Obesity is a significant independent risk factor for stillbirth, with women with obesity facing approximately double the risk of stillbirth compared with normal weight women in large population-based studies. Similarly, beyond neural tube defects, which we already talked about, there are increased risks of congenital heart defects, orofacial clefts, and limb reduction defects that have been shown in some studies, though the absolute risks of these still remain low. And for preterm birth, obesity is both paradoxically associated with both indicated preterm delivery, that's because of maternal or fetal complications that require early delivery, and spontaneous preterm birth, with women with obesity having approximately 20 to 30% higher risk overall of a spontaneous preterm birth. Finally, perhaps the most sobering from a public health perspective is the growing evidence around the developmental origins of health and disease in relation to consequences for the children who are born to women with obesity. These children have been found to have elevated risks of developing obesity themselves later in life, an elevated risk of insulin resistance, type 2 diabetes, and even cardiovascular disease themselves in later life. That's thought to be primarily driven by some epigenetic changes, variation in the hypothalamic programming of appetite regulation, and even altered gut microbiota that's established in utero and in early life. Obesity during pregnancy can thus risk perpetuating an intergenerational cycle of metabolic disease in the children as well.
And we have another wonderful podcast on that with Professor Chittaranjan Yajnik, which listeners can find through the NNI website or app. So some of these risks can be ameliorated by modulating the amount of weight gain in pregnancy. In many countries, weight gain advice is calibrated against a mother's existing BMI. You've done a lot of work on this topic. Can you start, Nandita, by summarizing the advice issued by the US Institute of Medicine, IOM? And this probably led the way in the world, although there's a lot of new information emerging now.
Indeed. This is a topic that's close to my heart. The IOM, the Institute of Medicine, or what's referred to as IOM, has now officially been renamed to the National Academy of Medicine. But I will continue to use the IOM for sake of consistency with some of the guidelines. The IOM has been a key body shaping gestational weight gain guidance globally. We know from physiology of healthy pregnancies that a healthy pregnancy involves expansion of blood volume, growth of the uterus and placenta, amniotic fluid, breast tissue, and growth of the baby itself, all of which result in weight gain during pregnancy. In 2009, the IOM guidelines were revised in a landmark effort, which was a significant step forward from their previous 1990 version to explicitly stratify recommendations for weight gain by maternal pre-pregnancy BMI. And critically, in these revised guidelines, the IOM introduced an upper ceiling on weight gain for women with obesity for the first time. However, an important limitation that researchers have flagged since the release of the 2009 IOM guidelines is that these guidelines did not differentiate between the obesity classes. Obesity class 1 being BMI, women with a BMI between 30 to 34.9. Class 2 defined as BMI of 35 to 39.9. And class 3 are women with a BMI greater than or equal to 40. And these risk profiles between obesity classes are quite different. There's now compelling recent evidence that for women with severe obesity, that even or in class 2 or class 3 obesity, this restricted 5 to 9 range of weight gain that's recommended by the IOM might still be too liberal, and that minimal or even zero net weight gain may be associated with better outcomes without compromising fetal growth.
Okay, so let's now try and put ourselves in the place of a woman, difficult for me. Let's say with a BMI of 35 kilograms per meter squared or so, and who's pregnant. What would be the current advice in terms of diet and weight gain for such a person, Nandita?
The general advice for all pregnant women, regardless of their pre-pregnancy BMI, is to consume a healthy diet during pregnancy that contains adequate energy, protein, vitamins, and minerals that's obtained through a consumption of a variety of foods, including green and orange vegetables, meat, fish, beans, nuts, pasteurized dairy products, and fruits. Now, I quote here the general advice from the World Health Organization, which arguably is in line with almost all national and international professional societies and governmental organizations. So this is quite consistent. Practically speaking, from the perspective of a woman with a pre-pregnancy BMI of 35, now she falls into a category of obesity class 2. So under the IOM guidelines, the recommended gestational weight gain target would be about 5 to 9 kilograms over the whole pregnancy for this individual. However, as I mentioned in the previous question, recent evidence suggests that for women in this BMI range, gaining below that lower limit of 5 kilograms does not actually increase the risk of adverse outcomes. So we should communicate the target range while not causing alarm if the gain is modest. The key message is to avoid excess weight gain, and it's important to dispel the myth of eating for two, quote unquote.
Now, briefly, just say a few words, if you would, about exercise in pregnancy. Is it okay?
It's very okay. The good news here is that evidence strongly supports physical activity as both safe and beneficial in pregnancy, including for women with obesity. And these are guidelines that are adopted by the WHO, as well as those in the US-focused American College of Obstetrics and Gynecology. The general recommendation is at least 150 minutes of moderate to intense aerobic activity per week, spread across most days. And this means something like brisk walking or swimming, for example, would be excellent examples of low-impact options that are particularly suitable in the context of obesity to reduce joint loading. It's important that women who have been sedentary, however, start and build up gradually, that rather than starting abruptly into exercise. And there are lots of different beneficial aspects of promoting exercise during pregnancy, including reduced risk, particularly for women with obesity, for gestational diabetes, as physical activity improves insulin sensitivity, and reduce risk of hypertensive disorders of pregnancy, among other benefits. For women with uncomplicated pregnancies, exercise carries minimal risk, but contact sports should generally be avoided.
So we've talked a bit about advice for individual women. Some may adhere to it and some may not. Let's end, if we may, by getting you to summarize the very many trials that have been conducted to try and reduce adverse pregnancy outcomes in overweight women.
This is an area that's both fascinating and somewhat humbling. Despite many well-designed trials, the overall picture of intervention studies is somewhat modest effects, and translating that evidence into population-level change remains a significant challenge. As you noted, there have been several trials of lifestyle interventions during pregnancy among overweight or obese women, and in multiple large systematic reviews and meta-analyses that have synthesized the evidence, the interventions have varied in their components, such as including dietary counseling, structured exercise, behavioral support, digital tools, and also in their format, including in-person, telephone, and app-based, and as well as in their intensity. What this means is that there's been a lot of different approaches to intervening for lifestyle interventions. The consistent finding across systematic reviews is that lifestyle interventions can reliably reduce gestational weight gain by an average of about 2 kilograms, which is a statistically significant but modest effect. Some trials have found larger effect sizes, but they tend to be of smaller sample size. There's a noted trend towards reduced risk of higher gestational diabetes mellitus, though many individual trials are underpowered to detect this definitively. There's less consistent effects on cesarean section rates, preeclampsia, and macrosomia, and birth weight in the meta-analyses to date. So because of the multiple mechanisms, these more less common outcomes are difficult to parse out. Even though there is heterogeneous data from trials on interventions, there are several important themes that have emerged from the trial literature. The first is that preconception intervention is likely to be more effective than antenatal interventions because many of the pathological processes start at the point of conception. So really focusing on optimal pre-pregnancy BMI before conception is really important. The intensity of the interventions matter a lot. More intense interventions and programs with individualized dietary counseling tend to show a larger effect than lower intensity written advice or general advice. The behavioral support or behavioral change support that's provided either through motivational interviewing, goal setting, or self-monitoring also has an important effect on the effectiveness of a given intervention in a trial. And then finally, equity and access matter a lot. The women who are most in need of support are often least able to access in-person programs, underlining the importance of remote and digital delivery models that are starting to emerge in this literature. So the field is really still evolving. I think the honest summary is that we know what to recommend and the biology broadly supports it, but translating that into practice at scale, particularly for women from lower socioeconomic backgrounds who carry a disproportionate burden of obesity, remains the great unsolved challenge still.
Nandita, thank you so much for walking us through all the pathology that is associated with body weight and pregnancy. It's really been a pleasure to gather all your expertise on this. And so it remains for me to sign off in the usual way by encouraging you, our listeners, to share this episode if you've enjoyed it and leave comments on whatever program or platform that you access it from. Please also subscribe through the NNI website or the NNI 365 app to ensure you don't miss future conversations.
Thanks for listening to Milestones. Explore more expert insights on the Nestle Nutrition Institute website and follow us on our social channels. See you next time for another milestone in nutrition.